Hello everyone, I'm Ron Waksman from the MedStar Washington Hospital Center. We are at the ACC 2014 in Washington, D.C. And with me today, Dr. Mohamed Abdel Wahab from Baden-Württemberg in Germany. Welcome.
Thank you. Thank you.
And you presented today a very provocative study, which is called the CHOICE study.
Yes.
So tell us how this whole study came about. What was the rationale? Why did you do?
So, as you're aware of, the use of transcatheter aortic valves has been expanded in the last years and has been rapidly adopted by interventional cardiologists and cardiac surgeons, both in Europe and the United States. And since its introduction, there have been two device types that have been used, which are on one hand the balloon expandable device and on the other hand the self-expandable device. And although both devices have different design and different characteristics, they have never been compared head-to-head in a randomized controlled trial. There were some data available from registries, both European and Canadian registries, that have shown some differences in the performance of both devices. But of course it was difficult to draw firm conclusions from that. And this is why we thought it's about time to do a head-to-head randomized comparison.
So the devices that you were studied were the Sapien XT and the core valve.
Yes, this is true. Exactly.
And what was the hypothesis on the study?
The hypothesis, which was based on the previously mentioned observation registries, was that the device success could be higher with a balloon expandable device, which was mainly thought to be due to a lower rate or lower frequency of more than mild prosthetic valve regurgitation, a finding that has been documented in the French and the UK registry as well as in the Canadian registry.
So what was the definition for success? Because there was a big difference.
Yes,
that's why I'm asking for the definition.
This is true. So the definition of success was adopted from the Valve Academic Research Consortium recommendations from the first
paper.
The VARC. Yes, from the VARC recommendations, from the first VARC definition to be accurate, which was the definition available at the time we designed the trial. Unfortunately, this definition is not being used in most of the trials to describe device success. But it's an important definition which describes the success of vascular access, the success of the implantation in the proper position, the function of the device without significant residual stenosis and without moderate or severe regurgitation, and finally it defines success as the final implantation of only one valve. So it's a composite endpoint including all these aspects.
And what was driving the unsuccess? It was mainly because of AR or because of residual stenosis?
So in the CHOICE trial we observed a higher device success rate with the balloon expandable device, which was due to two reasons. The first one, the less frequency of moderate or severe prosthetic valve regurgitation, which was almost completely due to paravalvular leaks. And the second one is the less frequent need for implanting more than one valve to obtain an adequate hemodynamic outcome.
And the study was conducted in 5 centers.
It was conducted in 5 centers in Germany.
And overall, for how long? What was the period of time?
We started enrollment in March 2012 and we ended the study in December 2013, so almost 18 months of enrollment.
And the totality of the number of the patients in the study?
241 patients were eventually enrolled and randomized. Equally distributed between both arms, 121 in the balloon expandable and 120 in the self-expandable arm.
So one of the questions that I was asked before, and you may have said it in your presentation, the valve size was determined based on what? It was echo, CT, MRI. What was the methodology for that?
So all the centers that participated in the trial had a very huge TAVR experience before starting enrollment in this trial.
So these are TAVR experience centers?
Yes, with a total volume of 1,500 TAVR procedures, almost equally divided between both valves before starting the trial. And so the sizing was mainly based on an integration of a lot of imaging modalities, mainly echo and CT, but in the steering committee strongly recommended the use of a three-dimensional imaging modality, namely multi-slice CT, which was actually used in 80% of the patients to determine the valve size.
So in 80% of the cases, CT was used?
Yes, this is true.
Okay, that's an important observation. So in summary, what was the outcome of the study, of this comparison?
So as previously mentioned, the primary endpoint, which was device success, occurred or was higher in the balloon expandable group compared to the self-expandable group, which was statistically significant. As for secondary outcome measures, we looked at events at 30 days, and almost all major events were low and comparable between both devices, so no differences in mortality, which was between 4 and 5% at 30 days. No differences in major stroke, which were as low as 2.5%.
What was the overall mortality of the two cohorts? It was similar, right?
4.1% in the balloon expandable group and 5.1% in the self-expandable
That was
group.
in hospital?
This was 30-day mortality.
30 days. And at 1 year?
We're still following these patients up.
So you don't have the 1 year?
So we don't have these data yet, but we are planning to do a follow-up down to 5 years.
Mm-hmm. And the aortic regurgitation was higher in the self-expanding compared to the balloon expanding?
Yes, this is true. It was higher using angiography, it was higher with the echocardiography, and it was even higher when you did a cardiac MRI sub-study in 90 patients, which confirmed the angio and echo findings.
One of the things which was striking in your presentation was the pacemaker rate. It was 37 versus 17,
Yes.
which for both it's like inflated maybe by
Yes.
a good 10 to even more percentage for each. What's the explanation for that?
This is a very important observation, and we noticed that the rates were higher with both valves. We think that this may be due to the lack of standardized criteria for permanent pacemaker implantation after TAVR, and because implanting a permanent pacemaker was not the primary endpoint of the trial, we did not specify specific recommendations for the centers, and we think that most of the implanting centers had a rather low threshold for implanting permanent pacemakers. For example, a lot of patients had permanent pacemakers because of the development of a combination of left bundle branch block and a first-degree AV block. So not all of them received the permanent pacemaker.
So overall, those
advanced
centers
AV
had
block.
a lower threshold to put pacemaker. That's
Yes.
your explanation.
This is one thing. The other thing, I think, we were very meticulous in trying to achieve optimum results without residual leaks. And this has been reflected to very low paravalvular leaks with both devices at 30 days. But to do this, we had very generous oversizing based on the three-dimensional CT images. So oversizing between 15 and 30%, which could also have contributed to the higher pacemaker rate.
Now, one thing that I found out in Germany, it's probably true also in the US, you have the partner sites and you have the core valve sites. So those sites, those 5 sites that were participating, they were primarily partner sites or primarily core valve sites?
They were primarily, or they primarily started as core valve sites.
As core valve?
Yes, because this was a general practice in Germany, especially for centers that wanted to start their program with a purely percutaneous approach. And at the time we started, or most of the centers started doing TAVR in 2007, 2008, the sheath size of the core valve device was much smaller than the early generation SAPIEN device. And this is why most of these centers started their program with a
all
core
those
valve.
centers were very experienced with core valve?
Yes, this is true. Most of the centers actually started using the SAPIEN device 2 or 3 years after
Now you
their
said
core
in
valve
your
experience.
presentation that these were high-risk patients, but when I look at the STS score, it was a little bit under 7. It was 6 point something.
Yes,
So
that's true.
they were not that high risk based on the US criteria, right? Maybe
This is right.
in Germany they were still considered high
This is
risk.
right. This is right. So if you look at the STS score, they're rather in the intermediate range. If you look at the logistic Euro score, it's well above 20. It's rather in the high range. But this is right, like the real world practice currently in Germany and in Europe, where a lot of these formerly intermediate risk patients are being treated with TAVR after a heart team decision.
The last question I would ask you is something that I think was raised during your discussion, the discussion after your presentation. We heard yesterday about the core valve high risk group, and the results looks phenomenal, nice, good. With
Fantastic.
So, but they are not in line with the results that you're showing if you just look at the core valve group by itself. So where is the discrepancy? Why they are not corroborating exactly the results that you are doing?
I'll be very cautious to compare the two trials because they are different by design, but nevertheless, I don't agree with you completely that the results are not in line, because if you look at the hard clinical endpoints that were examined in the core valve US trial, the numbers were very similar, except for the rate of permanent pacemaker implantation. So mortality and stroke, bleeding and vascular complications were very comparable. As for the leak issue, we didn't see the numbers for angiographic leaks in the core valve US trial, but if you can compare the echocardiographic findings, they're also very similar. They're even less so in our trial.
So you feel that there is more similarities than dissimilarities between the...
I think so, and of course it's difficult to compare, but there are a lot of similarities regarding the hard clinical endpoints.
So what's going to be the implication of this study? First of all, congratulations on a JAMA paper. That's a nice accomplishment by itself. But do you think that this result should change practice right now in Germany, or we're going to have in the US soon also the XT approved, so we'll have a choice?
Yes.
And since this is the only head-to-head randomization, what would be your message right now?
So I think the implications pending the longer-term follow-up data, of course, would be that if you have the choice between both devices in a patient that has a suitable anatomy for both devices, and you have the necessary experience with both devices, then probably using the balloon expandable valve would lead to more predictable results. So it looks like it's more predictable.
So you believe in the data and you would recommend
Yes.
to use more balloon expandable?
If you have the necessary experience to do this, I would recommend to do this, pending the long-term outcome data. On the other hand, there are some patients that are only treatable with one or the other device, and there were some patients that are probably may do better even with the self-expandable device that were not included in the study. For example, patients with degenerated bioprosthetic valves. We know from a large global registry that using a self-expandable device in this case results in lower gradients.
Okay, well, this is interesting. I think that the data definitely provocative.
They are.
I think it's going to create a lot of interest. I'm sure there are going to be a lot of followers. This is maybe the first randomized study between XT and core valve. I would project here on the record that probably there will be more to follow. So it would be interesting if your data would be corroborated or would be challenged by some future studies. But thank you very much and congratulations.
Thank you. It's my pleasure. Thank you.